Assalamualaikum warahmatullahi.
Waalaikumsalam, Doktor.
Everyone is ready, yeah?
Doktor, another one person.
Okay, all right. Just hang on for 1 minute. If not, then we start.
Okay, Doktor. Doktor,
All right.
another one person having internet problem. Do we to proceed
Kita
with
start
the
dulu.
first? Okay, Doktor.
Then you message dia, suruh dia try pakai dia punya mobile tu.
Alright, Doktor.
Nanti we start dulu.
Can you hear me?
Yes.
Okay. Assalamualaikum. My patient, Nadine Camilla, a 2-year 4-month-old Malay girl with underlying allergic rhinitis, presented with fever, cough, and runny nose for 3 weeks. History taken for her biological mother on the 2 of admission. History started 3 weeks ago when she developed fever, cough, and runny nose. The fever was intermittent in nature. Recorded temperature at home between 38.2 to 39 degrees Celsius. No chills and recall. It resolved temporarily with paracetamol 6 hourly. It was associated with chesty cough and runny nose with clear nasal discharge. No barking and whooping cough, no prolonged bout of cough, and no facial congestion. She was brought to see general practitioner on the 4th day of illness and treated as tonsillopharyngitis. She was discharged home with augmentin for 7 days, claim being compliant to the antibiotics. The symptom improved during 1 week of antibiotic treatment. 1 week later, she had another episode of high-grade fever, cough, and runny nose, and was admitted to IMSC for 2 days. Chest X-ray was done. She was treated as atypical pneumonia. She was given nebulized salbutamol once, IV cefuroxime, and had done chest physiotherapy twice. She was discharged home with tablet cefuroxime, azithromycin, Avamys, and loratadine. She had completed a 7 day course of tablet cefuroxime and 3 day course of azithromycin. The symptom improved. Her fever resolved for 1 day. However, she became feverish again 1 day prior to current admission. Her mother became more worried as the fever did not resolve. Upon taking 6 hourly paracetamol, documented temperature at home was 39 degrees Celsius. Her chesty cough and runny nose become worsened, which disturbed her sleep. In addition, she also had occasional post-tussive cough for 3 weeks. The vomitus was food and mucus content, about 1 tablespoon for each episode. Last post-tussive vomiting was 2 days prior to the current presentation. Apart from that, she also had reduced oral intake and loss of weight for 1 kilogram in 3 weeks. Normally, she would have 1 scoop of rice twice daily with 5 to 6 bottles of formula milk. But during the illness, she only can tolerate half cup of porridge and a bottle of milk per day. She also become less active and increased in sleeping. Upon further questioning, she was last sent to the nursery home 3 weeks ago, which was 1 day before she developed fever, cough, and runny nose. But her mother was unsure of any sick contact at the nursery. On the 6th day of illness, she was sent to her grandparents' house. Her mother claimed that her grandfather had intermittent non-productive cough. Otherwise, no rapid breathing, no facial pain and nasal congestion, no symptom of urinary tract infection such as dysuria, hematuria, urgency and frequency, no diarrhea, no joint pain, no night sweats and TB contact, no COVID-19 contact, no yellowish skin discoloration, no recent history of jungle trekking and water contact, and no rat infestation at home. In the emergency department, chest X-ray and a few blood investigation was done. Her mother was told that the chest X-ray worsened compared to a previous chest X-ray taken at the IMSC. She was given shrub paracetamol. In the ward, she was given IV cefotaxime. And during the clocking on the 2nd day of admission, her condition improved, in which she had increased in oral intake. However, no fever. However, she still have intermittent chesty cough and runny nose. For the past medical surgical history, she had history of fever, cough, and runny nose for 1 week in January 2022, treated as upper respiratory tract infection. Her symptom resolved upon completing a 1 week course of augmentin. She also had episode of upper respiratory tract infection 2 to 3 times last year and resolved upon taking antibiotic treatment. She also had underlying allergic rhinitis, newly diagnosed during her last admission in IMSC. She had not undergo any surgery previously. For the past medication and allergic history, currently on Avamys and loratadine once daily, being compliant to the medication with no side effects, no drug allergy. For the perinatal history, antenatally, her mother was 30 years old and had oligohydramnios during the pregnancy. She was born at 37 weeks via spontaneous vertex delivery with birth weight of 2.8 kg, no history of an ICU admission. She had episode of prolonged jaundice, started on day 2 of life and had to be put under phototherapy for 1 week. Her mother blood group was O positive. For the developmental milestone, her development was appropriate for age. Gross motor, she is able to run and kids large ball gently. She is able to jump with 2 feet together. For the fine motor, she is able to do pincher grip and copies vertical stroke. For the language and speech, she is able to speak 2 to 3 words phrase and follow commands. For the social, she can eat by herself, able to use spoon and actively play with her brother. For the immunization history, she had completed all immunization according to National Immunization Program with no side effects and no additional vaccine taken. For the nutritional history, she had exclusive breastfeeding up to 1 year old. Currently, she is on formula milk, brine Pedisure, about 6 ounce 5 times daily. Started weaning at 6 months old. Currently, during breakfast, she would have roti canai, nasi lemak, or nasi ayam. Lunch, 1 scoop of white rice with 1 piece of fish or egg and sayur masak lemak. For dinner, same as lunch. Her mother admit that Nadine is a picky eater, but as she did not eat chicken, no food allergy, current body weight 12.4 kilogram, above the 50th centile. For the family history, her father is 33 years old, worked as engineer, had childhood asthma, but had already resolved. Uh, Her father currently has allergic rhinitis on medication. Her father is not a smoker. Her mother is 33 years old, works as pharmacist at HTAA, has allergic rhinitis on medication. She has an elder brother, 6 years old, had underlying asthma and allergic rhinitis on medication and proper follow-up. For the social history, she lived at Pematang Badak with her family, about 15 minutes far from the suspect. 4 occupants in a house. The nearest clinic is KK Pematang Badak, about 5 minutes away. Nearest hospital is HTAA, about 10 minutes away. Her father worked as engineer offshore. Come home only once a month. Monthly household income about 13,000. Her elder brother currently had to be taken by their grandparents during her hospitalization. Doctor, should I proceed to physical examination?
Yeah, continue.
Okay. For the physical examination was done on day 2 of admission. On general assessment, she appeared alert, pink, and active, not toxic looking, no dysmorphic features. During physical examination, I can hear that she still have occasional chesty cough, and I can see that she had a yellowish nasal discharge. She was not in respiratory distress with respiratory rate of 36 breaths per minute. Body weight appropriate for her age. She had branula attached on her right dorsal of hand with no active infusion. Capillary refill time less than 2 seconds. 1 peripheries. No finger clubbing or peripheral cyanosis. Pulse rate was 132 beats per minute. Regular rhythm, good volume, no bounding pulse. No conjunctiva pallor, no scleral jaundice, no conjunctiva suffusion. Hydration status was good with no coated tongue and dry lips. No mouth ulcer, no strawberry tongue. She had injected throat and swollen tonsil, but no turbinate hypertrophy. No lymphadenopathy and no lid swelling. For the anthropometric measurement, body weight 12.4 kilogram on the 50th centile. Height 90 centimeter between the 50th and 75 centile. BMI 15.3 kilogram per meter square above the 50th centile. For the vital signs, blood pressure was 108 over 97 millimeter mercury, normotensive. Temperature 36.9 degrees Celsius are febrile. SpO2 98% under room air. On respiratory examination, there was no chest deformity, no scar, and no dilated vein noted. No tracheal deviation, no chest recession. However, on auscultation, there was fine crepitation heard over the right mid-zone with equal air entry. No other added sounds such as ronchi and pleural rub. Other system was unremarkable. As for the summary, my patient, Nadine Camilla, a 2-year, 4-month-old Malay girl with underlying allergic rhinitis, presented with unresolved intermittent high-grade fever, cough, and runny nose with clear nasal discharge for 3 weeks. She had completed 7 days course of augmentin, 7 days course of cefuroxime, and 3 days course of azithromycin during the period of illness. She also had loss of appetite, loss of weight, about 1 kilogram in 3 weeks, and become less active. She had no symptoms of she had sick contact with her grandfather. Otherwise, no repeat. There was on auscultation, there was fine capitation heard over the right mid-zone of the lung, and I can see that she had a yellowish nasal discharge.
Okay. All right. What's the provisional diagnosis on this admission?
As for the provisional diagnosis, my provisional diagnosis is partially treated bronchopneumonia,
Okay. All
as
right.
she had intermittent high-grade fever, chesty cough, and runny nose. And she also had sick contact with her grandfather on the 6th day of illness. And on physical examination, I can hear there is a fine crepitation over the right mid-zone. However, no repeat bleeding.
Other differential diagnosis?
Other differential diagnosis would be COVID-19, as she had a fever, chesty cough, and runny nose. However, there was no COVID-19 contact. Other differential that I would like to rule out is pulmonary tuberculosis, as she had prolonged cough, fever, and weight loss. However, there was no night sweats, no TB contact, and on physical examination, there was no lymphadenopathy. And other differential would be rhinosinusitis, bacterial origin, bacterial rhinosinusitis, as she had high-grade fever. And on physical examination, I can see there was a yellowish nasal discharge. However, there was no turbinate hypertrophy on physical examination. And in the history, there's no complaint of facial pain or nasal blockage.
All right.
And as
Anything? Continue.
as she had prolonged fever, I would like also to rule out urinary tract infection. However, there was no symptom of urinary tract infection such as frequency, urgency, dysuria, and hematuria.
Okay, right. Another one, I mean, because if you don't have the chest X-ray initially, always consider that whether this child has empyema or lung abscess because of the prolonged fever. Always consider that as well. Okay, what are the investigation you want to do for this admission?
As for the investigation, as my provisional diagnosis is bronchopneumonia, thus I would like to order for full blood count to look for leukocytosis in the case of infection, particularly neutrophilia.
Do you know what's the patient's blood result? FBC for this patient?
Patient's blood result.
What's the count?
White cell
It's
count normal.
Yeah. Why do you think it's normal?
Because had already previous history of getting antibiotics.
Right. Okay. Always consider that if you have this result like this, that's why we say the diagnosis is partially treated. So don't consider that because it's normal. Then there's nothing significant. You always relate that this child has already received antibiotics. Okay. Any other investigation?
Other investigation I would like to order is inflammatory markers such as CRP and ESR.
Was it result like?
The result CRP high 4.3.
Okay.
ESR also high 71.
All right. Okay.
Yeah, ada investigation, blood culture and sensitivity to know the causative organism.
Okay.
Ada blood test is a liver function test to look for albumin level, because this patient had reduced in oral intake. Therefore, I would like to look at the albumin level to assess the nutritional status of the patient. Other blood investigation is renal profile to assess the hydration status of the patient. Expected finding is hypernatremia in dehydration, and also increase in urea and creatinine in the case of AKI secondary to dehydration. Other things would be COVID-19 rapid test to rule out COVID-19 infection, TB workout such as MEN2 test, sputum AFB, and also sputum MTB culture and sensitivity.
All right. Did the mental test was performed for this child?
Yes, mental test was done.
Negative.
Negative.
Okay. Okay.
Okay.
So yeah. So other special investigation you want to do?
Other things for the to rule out urinary tract infection, I would like to send for urine UFAM, urine food examination and microscopic examination to look if there is any bacteria, pyuria, hematuria or positive nitrates in the case of urinary tract infection. Other things would be chest X-ray to look for any consolidation in the case of pneumonia and also cavitation in the case of pulmonary tuberculosis.
All right, very good. So how do you manage this patient?
As for the management, firstly, I would like to secure the airway and breathing by giving the oxygen therapy via the nasal prong if the SpO2 less than 95%. However, this patient had tak tahu SpO2 waktu ini tak tahu. And then I would like to give IV fluid with crystalloid if the patient is dehydrated. Give antipyretic such as paracetamol, and then temperature charting, and then I would like to give antibiotic therapy to antibiotic therapy, and then lastly refer for chest physiotherapy.
Okay, just physiotherapy is important. Okay, quite clear. So what's the choice of antibiotic you want to use for this patient?
For this patient, usually in pneumonia, the first line would be augmentin. However, he already on augmentin. Second line would be cefuroxime. However, he already on cefuroxime. Therefore, I would like to give cefotaxime. Or also in the second line, for the pneumonia, cefotaxime.
All right, okay. So the choice of antibiotic actually varies between hospitals. If you're going to work in Klang Valley, say you work in Estimlaya or UKM, it will be a different type of regimen. So just be alert that the rationale you use antibiotic. Example, in KKM, of course, first line is penicillin, right? Penicillin, gentamicin. But in this situation, is there a role of penicillin?
For this patient,
Yeah.
I think no.
No, right. So you have to justify as a house officer, you can decide to initiate antibiotic, right? So if you decide that you have received this kind of history, 3 weeks of antibiotic, yeah, and then patient came to you in KKM hospital, of course you wouldn't want to start penicillin, even though the protocol is penicillin. So you have to justify. Okay, so don't just because KKM see penicillin, and this patient also you give penicillin. You have to justify to the medical officer and say that this patient has a partially treated pneumonia, already been received what they call this different type of antibiotic doesn't work. If receive amoxiclav like augmentin, it doesn't work, means that penicillin doesn't work. So you have to choose a different type of antibiotic. All right, correctly. Any question to siapa Sharifah? Any question to her? So this child for the past 1 week has been discharged before you left the HTA.
Masa pergi HT itu tak discharge lagi.
Alright, okay. Okay, before I forgot, how's the situation in HTA? What's the general ward like? Because I heard Dr. Azhar saying that there are many COVID patient are they in the general ward? Can you go to general ward?
Yes, doctor. Still can go. But the isolation room cannot enter lah sebab untuk COVID patient.
But the COVID patient are in the general ward as well?
Yes.
Oh, okay, alright, okay. Okay, alright, we move on. Do you have another presentation?
Yes, doctor.
Okay, continue.
Okay, so I will continue with the second case. So I have got this patient named Afif Rizki, a 3-year-old Malay boy with normal development and no medical illness previously, presented to emergency department of Sussex because of one episode of seizure with fever on the day of admission. So the history was taken from his mother. The child was apparently well until 2 days prior to admission when he started to have fever, which was gradual onset. The mother noticed the child had fever with warm on touch, and the fever was associated with chills and rigor. The commented temperature at home was 38 to 39 degrees Celsius, and the mother tried to relieve the fever with giving tepid sponging and also syrup paracetamol every 6 hours. But the fever just resolved temporarily with the medication. And on the next day, which was on the second day of illness, the child started to have cough, which was dry, intermittent in nature. The mother was unsure of any aggravating and relieving factor. However, there was no whooping or barking cough, no prolonged bouts of cough, no facial congestion, and post-acid vomiting. And on the same day, the fever was still persistent, which relieved temporarily with the paracetamol given every 6 hours. So because of that, at that night, the mother tried to bring the child to clinic Safwa. And at the clinic, the mother and the child was told by the GP there that the child had slightly swollen and inflamed tonsil. And then he was treated with suppository paracetamol and given syrup paracetamol upon going home. And then on the third day of illness, which was on the day of admission, the mother described that the fever was still persistent with similar pattern of resolving temporarily with the medication. But the child started to have vomiting for 2 episodes with food content, minimal amount, no blood or bilious content, and it was non-projectile. And in the evening at 6:30 p.m., the child developed 1 episode of seizure. It happened when the mother was chatting with the child who was lying in supine position, and suddenly the mother noticed that the child became quiet, and there was uprolling of eyeballs and lateralization of face towards the right side. And the mother noticed that there was both upper limbs and lower limb become stiff. It happened about 2 to 3 minutes and aborted spontaneously. However, there was no jerking movement, no drooling of saliva, no foaming at mouth, no jaw or teeth clenching, no perioral bridge discoloration, and trouble breathing during the seizure. The mother did not notice and was unsure about any bowel or urinary incontinence as the child was wearing diaper. And post seizure, the child developed post-ictal drowsiness and become sleepy for about 10 to 15 minutes. And because of that, the mother brought him immediately to emergency department. And actually in emergency department, the child developed another 2 episodes of seizure with similar pattern. But the mother was unsure about the gap between those 2 episodes. And on day 1 of admission in the ward, when the child was treated with antibiotic and also paracetamol per orally, the child developed another 2 episodes of seizure, despite being on IV phenytoin. And on day 1, and on the same day, the mother claimed that mother noticed the child might have altered behavior, evidenced by the child become very irritable, had inconsolable cry, and aggressive behavior when the child tried to remove the granula, and the mother was unsure how to calm the child. But there was no loss of consciousness. So apart from that, throughout the period of illness, the child was still active during first and second day of illness, but on the third day of illness, the child had reduced oral intake. Usually, the child drink about 6 to 7 bottles of milk with 3 meals of adult diet. But during that day, prior to admission, he can only tolerate 1 bottle of milk and only eat small amount of jelly. And the last meal taken was 1 bottle of milk with jelly, which is 1 hour prior to the onset of seizure. And he was also become less active on the day of admission, where he just slept a lot at home. Otherwise, there was no runny nose, no rapid breathing, no noisy breathing, chest pain, abdominal pain or diarrhea, no ear discharge, no conjunctival suffusion, no skin rashes or blister, no false smelling of urine. And the mother denied that the child had any turning away from the lights or arcing of the back and a headache. So upon further questioning, actually the child had a history of sick contact with elder brother who had URTI symptoms, but there was no history of COVID-19 contact, travel or going to crowded places. Actually, this was his first episode of having febrile seizure. The immunization, the child took full immunization up to his age, no added vaccination, no recent vaccination, and no history of recent, no history of having recent chickenpox or exposure to the chickenpox contact, no history of TB contact, and no family history of febrile seizure or epilepsy. There was also no history of recent water activity, no history of trauma or fall. So for the past medical and surgical history, this was second hospital admission. First admission was 3 years ago in suspect when the child had influenza, and the mother claimed that the child have lung infection, which I think is pneumonia. Otherwise, the child did not have any other known medical illness and never done surgery before. The child also did not have any drug allergy and food allergy. For birth history, antenatal was uneventful. He was born in HTA at 36 weeks period of gestation via emergency lower cesarean section. Because of the unstabilized in twin pregnancy, and the birth weight is low with 2.2 kilogram, but there was no any ICU or SCN admission and no complication after the birth. And postnatal was also uneventful. For developmental history, the mother claimed that the child was growing well, appropriate to his age, and the child has a normal developmental milestone up to his age, where for the gross motor, he can walk on tiptoe, can stand on one foot, go upstairs, downstairs, and also kick ball. For fine motor, he can copy, circle, and then for speech and language, he can tell his full name 2 colors. And for social, he now can eat independently and very active playing with other children. For dietary and nutritional history, he was on exclusive breastfeeding up to 1 month duration. Currently, he was on adult diet, 3 meals per day, where for breakfast, he eats mee goreng. For lunch, he usually eat 1 scoop of rice with chicken or fish, or meat and vegetables, and same with dinner. The meals for lunch and dinner are same. So far, the child is not a picky eater, and he also still drink formula milk, 6 to 7 bottles per day on demand. So for the family history, his father is 38 years old, is a technician, no smoker, but having asthma on MDI salbutamol. His mother, 38 years old, having no medical illness, working as a teacher at Tadika Kemas. And the child actually has identical twin. So he has 1 elder brother and 1 elder sister. The elder sister currently is 10 years old, no medical illness, and elder brother 6 years old, also having asthma on MDI salbutamol with fluticasone. For social history, he lives in Kotasas, 7 people per house, as grandmother also live together with them. And during working hours, the child was taken care by the grandmother. The nearest klinik kesihatan is KKIM, about 5 minutes, and the nearest hospital is Susmed, about 10 minutes. The house so far was adequately equipped with good facilities, water and electric supply. The total income for the family is about 5K per month. So for physical examination, on general examination, the child was lying on the bed. He was sleeping. But he looked pink, not in respiratory distress, with respiratory rate of 32 breaths per minute. For the size of this chart, look appropriate to his age, but I would like to confirm by plotting on the growth chart. There was no dysmorphic features. There was granular attachment or right dorsum of hand with active infusion of IV phenytoin. He was also on nasal prong at the flow rate of 8 liters per minute. On peripheral examination, the hands were warm, no peripheral stenosis, no koilonychia. Capillary refill time was normal, less than 2 seconds. No skin rashes, no blister, noted on the skin. For eye examination, no conjunctiva pello and scleral jaundice. I didn't get the chance to examine the mouth as the child was sleeping, and there was no leaf adenopathy. For anthropometric measurement, his weight is 11.7 kilogram on 5th percentile, height 93 centimeter, just above the 25th percentile. Making his BMI is 13.5 kilogram per meter square, which is below 3rd percentile. Okay, for vital signs, BP was normal, 95/60 meter mercury. Heart rate also normal, 120 beats per minute. Temperature is 37.9. He was febrile. SpO2 normal, 98% on nasal count. So for the neurological examination, on inspection, there was no cutaneous stigmata like Griffith only, no abnormal posture, no muscle wasting, no involuntary movement and fasciculation. The tone for both upper limb and lower limb normal. For the power, I didn't really assess as the child was sleeping, but then during clacking, before the child was sleeping, as the child moved, so I can say that the power is at least 3/5 for both upper limbs and lower limbs. And there was hyperreflexia, so noted, but there was no proneness, and Babinski sign is negative. For sensory, cranial, and cerebral examination, I could not assess, and I also could not assess for Brzezinski sign and clinic sign in this child, unfortunately.
Okay, so your provisional diagnosis,
So in this
the first one, what we should be.
in this case, I would think of something to do with intracranial pathology, which could be encephalitis.
Okay, right. So that should be the first one, right?
Mm.
It should be encephalitis. Right, other differential?
Other differential, it could be meningitis
Okay.
or also a meningoencephalitis. And then other than that, it could be space occupying lesion like cerebral abscess, or also brain tumor. But then the child had non-projectile vomiting and no like headache, any signs of increased intracranial pressure. The differential could be complex febrile seizure, secondary to a few differential diagnoses, which is it could be acute tonsillitis or pharyngitis, because at private clinic, the GP thought that the child had inflamed and swollen tonsil. And then it could be that the child might have complex febrile seizure secondary to URTI, as the child had fever and also cough, but no runny nose. And then it could be that the child might have complex febrile seizure secondary to pneumonia, but then the child had no chesty cough, no rapid breathing. And then could be because of UTI, but no signs and symptoms of UTI and also forced smelling urine. Other than that, the child might have seizure secondary to metabolic derangement like hypoglycemia, because on the third day, which was on the day of admission, the child had reduced or intake, just take 1 bottle of milk and also small amount of jelly. And then the next one, seizure because of electrolyte imbalance, like hyponatremia, hypokalemia, or hypocalcemia, hypomagnesemia, and also hypophosphatemia.
Alright, very good. So most important thing is based on this history, shouldn't be febrile fit shouldn't be the first diagnosis because of the complexity of the presentation. Meningoencephalitis should be the first one. So what investigation you need to do on admission?
So on admission, the first one is on admission. Firstly, I would like to investigate for the cause. So first investigation, I will start with the common and simplest one, which is dextrostate glucose to rule out hypoglycemia. And then I want to proceed with blood investigation. First one is full blood count. First, because I would like to see for evidence of infection like leukocytosis. If there is leukocytosis, I would like to see is it neutropenia or lymphocytosis or lymphopenia. Is it suggestive for bacteria or viral origin?
Oh, this patient result, do you have a patient's result?
Oh yes, but for this patient, the result is normal.
Oh, no, within normal range, is it?
5.1.
What's the white cell count?
White cell count 5.1.
5.1, and then the lymphocyte?
Lymphocyte.
What's the percentage of lymphocyte?
Lymphocyte is 1.5.
1.5. Do you have a percentage? Is it 60%, 70%? Right? You know, the percentage of
12.5% here. Percentage 28.6, about 30%.
Alright, so it's neutrophilia. Okay, so other investigation?
Other investigation, I like to see proceed with electrolyte, serum electrolyte like calcium, magnesium, and phosphate, because I would like to rule out hypocalcemia, hypomagnesemia, and also hypophosphatemia as the cause of the seizure.
Right. What about this patient?
For this patient, I'm not sure, but I didn't see the result for this, so I think they did not do it, doctor.
How about the urea as the sodium, potassium? Any?
For sodium, it's low, 131.
Okay.
Chloride also low, 100. But potassium normal. Creatinine is low, 23.
What is potassium just now? Sorry.
Potassium normal.
Normal. So, but sodium is 131.
Sodium 131, yes.
Okay. Alright. So it's low. Okay.
Mm.
Any other investigation?
For other investigation, I would like to proceed with CRP as the inflammatory marker. And for this patient, it's normal 2.59, but 2.6.
Mm-hmm.
And then maybe I would like to proceed with blood culture and sensitivity in case of the bacteremia. And then I would like to proceed with liver function test because I would like to rule out any hepatic encephalopathy. And also like to assess the baseline before starting medication like antibiotics and also anti-epileptic that can cause hepatotoxicity. And then I would like to proceed with urine specimen doing urine analysis to rule out UTI. And also because the patient has reduced oral intake, so maybe we can see ketonuria because of starvation. And then what purpose imaging study? The first one is which is the most important in this case is CT scan of the brain with or without contrast to rule out any intracranial pathology, any hemorrhage, any specific contamination. Or
Is it done for this patient?
Yes.
Is
But
it
for
with contrast?
Without contrast.
Okay. What's any space of compilation? No.
No, the CT scan also normal.
Okay. So, but actually, if you suspect meningoencephalitis, right, the scan should be done as with
Contrast, so
contrast,
that we
right?
can
So
see
you can see
meningeal
the
enhancement.
meningeal enhancement, right? So
Mhm.
okay. Do you think this child need lumbar puncture?
Yes. Also did lumbar puncture after doing a CT scan.
All right.
So
Okay.
the lumbar puncture, the result is stated that appearance clear, white cell normal 10, and then the other also normal. Actually overall for the LP result, it's stated in the IP circuit all normal.
All right.
In,
Okay.
Indian ink and latex agglutination also negative.
All right. So on this basis, if child responded well to treatment, the final diagnosis should be what? What should be the diagnosis then?
Actually the child actually this child after he was treated with antibiotics, ceftriaxone, and also put on IV phenytoin. And when the child had fever, had seizure, they give diazepam, IV diazepam. But then on the second day of illness, the child developed a few episodes of seizure. And then the doctor there noted that the child had reduced GCS level, become drowsy and confused. So they intubate this child, and then this child was transferred to PICU HTA. And then I lost the track for this child.
You are in HTA, right? Probably just try to make a visit to.
Oh, can we go to PICU, doctor?
Sorry?
Can we go to PICU?
Yeah. Yes. Should try to get the permission from the MO. At least try to get the MO there. See that you wanted to know what's the progress, right? What's a child's what is a child's name? I need probably can ask Dr. Azhar see what's on.
Yeah.
What's a child's name?
Oh, child's name, Afif Rizki. Actually, I was also curious about this child since in this week we also posted in HTA, but then I don't know that we can enter the ICU.
AFIQ, is it?
Afif Rizki.
AFIQ.
AFIF.
Afif.
Afif Rizki. RIZQI.
RIZQI, yeah. Afif Rizki. He's a 3-year-old,
3-year-old.
Okay, I'll try to get the info. If anything, I can try to WhatsApp you. But you try to get permission whether you can get to know what's the progress. Probably you don't want to see the patient, but see what's the progress like since you are in HTA.
Oh,
All right.
that's great.
So what are the possibility for differential diagnosis like this is actually, let me see whether I've got this patient in our recent discussion. Do you know about MISC? Have you heard of MISC?
Yes, is it long-term COVID complication?
Not long term. It's actually
Multi-system inflammatory.
multi-system inflammatory, multi-inflammatory system, right? In childhood. So let me see whether massive state. All right. I think probably this is the patient. I think probably this is your patient. So I just share with. Later I'll share the EEG. I think most likely this is the same patient. So what happened is in this situation, quite odd patient. Right? Even though the COVID RTK is negative, so we are seeing many patients with, we call it MISC. So when we did antibody of COVID, antibody is positive, even though the child has never been diagnosed with COVID. Sometimes they have infection in community and without parent realizing it few months ago. And now manifested as MISC. You probably can Google MISC COVID, right? So they can present as like Kawasaki. In this patient, presented like encephalitis, and likely this child would have a condition called ANEC or ADEM, right? Possibility. It's a quite rare complication of post-COVID infection. So I think this the current workup. I think just today I've got the EEG from Dr. Asa was sharing with us. So likely this is your patient, right? So abnormal EEG. All right. So okay, I think the initial, but you can have a complex febrile fit presented as status epilepticus. Okay, patient has status epilepticus, then you do a lot of workout, then finally the diagnosis is actually what do you call this, complex febrile seizure presented as status epilepticus. It's not impossible as well, but since this patient has deterioration of DCS, then will be more than that. Usually status epilepticus in febrile fit, they will recover, and this patient fortunately they progress. All right, so we discussed of course the choice of antibiotic again. Most instances is either combination of penicillin and cefotaxime, right? That is the most common antibiotic in KKM hospital. Or the next choice is actually ceftriaxone, heavy ceftriaxone, right? This is antibiotic which can penetrate the CSF. Okay. Any question? Very good. Both are quite clear.
Doctor, I would like to ask,
Yep.
when I trace the result in hypersakit,
Mm.
one of the result is MDW. So when I Google, it is monocyte volume with distribution. Is it the monocyte volume distribution? Because in this child, his MDW is increased, 48.9.
What is the, in your FBC, right? What is the monocytes? What is the percentage of monocyte?
Monocyte. Percentage of monocyte is 12.5.
She's quite high, right? So what another possibility is actually this child could be having Epstein-Barr virus encephalitis, right? So EBV will be presenting as monocytosis, right? So whether this is true for this child. So this again, you need to do EBV serology to determine. So there's many causes. Actually, ideally the CSF from the lumbar puncture. Okay, so what would you want to send the lumbar puncture CSF from lumbar puncture for? Apart from biochemistry, right? The one that you mentioned is biochemistry, right? So what else should you send the CSF for?
Apart from the biochemistry, maybe we can say for serology, like Dr. mentioned just now, maybe can detect viral PCR.
So you send it for number one is a culture and sensitivity, right?
Okay,
Usually
sensitivity.
for determination of bacteria is for mainly bacteriology. And
Yes,
second one, you can send it for CSF for viral study, right?
very study.
So they will send to IMR, and then this will be run for a various type of viruses, lah, right? So probably you would probably know what infection will happen. If this is same patient, apparently I think the COVID antibody is positive. I think most likely this is patient.
Hmm.
Okay. Any other any what do you call this? So if patient has prolonged seizure, okay. So we have discussed just now is actually you can give infusion of phenytoin. Right. If it doesn't work, do you know what are the anti-epileptic you use if phenytoin doesn't work, or you have achieved maximum dose? Do you know any other anti-epileptic that probably you use?
Is it phenobarbital?
Yes, yeah, phenobarbital, right? This is a commonness. I think you probably know this. The rest would be very specialized treatment. Okay, very good. Any question relation to this two presentation? Both are quite very good case. Okay, so
Doctor,
yeah,
I would like to ask regarding the management for the status epilepticus. I would like to
okay,
clarify for where we've got the what we call established status epilepticus and the refractory status epilepticus, where the management for each differs according to the duration of the seizure itself.
mm-hmm.
May I know, for example, in the first 5 minutes we give IV diazepam,
Yeah,
and
okay.
for
Either IV or rectal
how
diazepam.
IV for
Either
the
you can give either IV or rectal, because
rectal,
if
okay.
you can't get IV access initially, right, you can give what you call this rectal diazepam, right? So usually it will stop this immediately. Okay, if this persists for the next 10 minutes, usually you can give another dose of rectal or IV diazepam. Okay, the moment it goes into more than 30 minutes, then it is called a status epilepticus by definition, right? Either prolonged seizure more than 30 minutes, or fail to prolonged seizure or have multiple seizure up to 30 minutes, right? So they didn't regain any consciousness within 30 minutes with either multiple seizure, or that one seizure become prolonged. Multiple seizure means that the child has seizure now, and then it stopped. In 5 minutes, another one, it stopped, but the child didn't regain any consciousness. For the next 30 minutes, it's still also considered as a status epilepticus. Or the patient has a seizure now, continuous seizure, right, up to 30 minutes, then we will consider it a status epilepticus. But in clinical practice, the moment it reach like 15-20 minutes, we wouldn't wait for 30 minutes. Unlikely it will stop. So that's why you see that we will intervene early, right? The moment that the seizure prolonged 15-20 minutes, definitely the child will receive his or her first IV anticonvulsive therapy, right? Either phenytoin or phenobarb. That is a common thing that we do. And then again, if it doesn't improve, we maximum dose, we give another one, right? Then you would consider securing the airway and intubate the patient if it's become protracted, because you want to protect the brain, right? Okay, quite clear. Any other question? All right, very good. I'm really sorry for the what you call this postponement. A lot of things happened this week. All right. So thank you very much. I'll give you the marks for both of you in the WhatsApp, and I probably will share the EEG of this patient to your WhatsApp. You can share around. Okay, all right. So we end up. Sorry. Sorry. We end up our session. Tasbih kifarah, sonas. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very
Thank you,
much,
Doctor.
Doctor.
Thank you.
Thank you, Doctor.